Okay, I think we're right to go.
Okay, so I'll start again for those that have just joined us. Good morning and welcome to this co-hosted event between Anchor Excellence and BestMed. Today we are joined by Cynthia Payne,
Hi, everyone.
Managing Director for Anchor Excellence, Dr. Irene Stein, Clinical and at Anchor Excellence, Sam Hijazi, Head of Business Services at BestMed and our pharmacist today, and myself, Sadie Burling, the National Head of Aged Care for BestMed. As I mentioned before, we only have 1 hour, but we will stay on the line for about 15 minutes post the webinar to answer any burning questions. Otherwise, there is a question and answer button where you can enter your questions and we will come back to you in due course after the webinar with some question and answer sheet. Following the presentation, you will also be provided with a link to the slide deck, poster on psychotropic medications, the BestMed brochure, and the restrictive practices scenarios put out by the Quality and Safety Commission. So if we go to the slide, Cynthia, for our objectives. There we go. You can see that there's a number of objectives we want to get through for the session, but in a nutshell, what we have is Sam discussing everything psychotropic, the most common used medications within the classes and how they affect our seniors. And then we have Irene, who's going to be talking about the clinical implications of psychotropic medications and how they relate to restrictive practices, and the risks that you should be aware of in your practice. And then, of course, we have Cynthia, who's going to give you some insights into the legislation and the provider, clinician and prescriber obligations in this area. So without further ado, we'll get on to everything psychotropic. Thank you, Sam.
Hi, everybody. What is a psychotropic medications? Psychotropic medications are chemicals that affect the mind, emotions and behaviour. Now, the aim is always to decrease or cease these medications, but they are useful in treating certain diagnosed medical conditions, and we're never going to get rid of them fully from aged care. The most common types, this is not an exhaustive list, but these are the most common types used in aged care: antipsychotics, anti-dementia medications, antidepressants, benzos, anticonvulsants, opioids, and antiemetics. Now, looking at the antipsychotics, they're used primarily to treat psychotic disorders and relieve symptoms of hallucinations, delusions, disordered thought. Most common medications used in aged care based on BestMed observations. Looking at the pie chart, quetiapine is sitting at 34%. That's the most commonly used one, followed by risperidone, then olanzapine, and to a lot lower extent, you've got the haloperidol and the aripiprazole. Now, it's very important that that you have an electronic medication management system, a good one that's going to help you manage these medications, manage the use. And basically, the medication management system should be guiding the prescriber on how to prescribe these medications, providing the facility with a lot of visibility on their use and effectiveness as well, through comprehensive reports and built-in tools. So the most common side effects or adverse effects with these medications include anticholinergic effects like blurred vision, urinary hesitancy, constipation, dry mouth, dry skin, and more severe side effects include intraocular pressure, fecal impaction, delirium, cognitive impairment, cardiometabolic effects, extrapyramidal effects, Parkinsonism, hyperprolactinemia, neuroleptic malignant syndrome, orthostatic hypertension, QT interval prolongation, which can lead to arrhythmias. So that's why a lot of the, before starting a lot of these medications, you need to be doing ECG and sedation. So basically, monitoring the use of these medications, especially when you start on these meds, or you have a dose increase or a change, is crucial. We need to monitor for risk and harm. We need to monitor for side effects. When the medication is administered, say for the next hour, the doctor has to set in how often should you be reviewing this resident. for these sort of type of side effects. Next one is the anti-dementia medications. They're drugs used to improve cognitive function. They do not cure or delay the progression of dementia. The most common causes of dementia, number one is Alzheimer's disease, and that's like in 50 to 70%, 75% of the cases it's seen, and then vascular dementia, that's the second one. Sometimes you can have combined mixed dementias where you've got two conditions leading to the condition. Looking at the pie chart, you can see there that Aricept, which is donepezil, is the most commonly used medication for dementia, sitting at 56%. Then you've got memantine, which is Ibixa, 21%. And then Exelon patches, which is rivastigmine, and then followed by Remenol, which is galantamine. So that gives you an idea of the most commonly used one in aged care. Again, they got a lot of side effects, so monitoring is essential, and these include gastrointestinal adverse effects, particularly nausea, vomiting, anorexia, weight loss, vivid dreams, urinary incontinence, tremors, cramps, bradycardia, dizziness, and drowsiness. So there's a lot of side effects, and it's crucial that the prescribers are weighing the risk versus benefit before charting these medications.
And just jumping in there, Sam and Irene, so this class or this family of medications being psychotropic medications, but Irene, this one in particular being anti-dementia, and Sam, it'll need to be captured to the psychotropic register, but it may in fact not be considered a chemical restraint. Now, we're going to come back to that a little bit later, but obviously, Irene, monitoring side effects has been an area of focus for polypharmacy and medications generally. Is there anything else you'd add with that?
No, just that it's really important that when the prescribing medical officer is absolutely crystal clear in the purpose of the medication, that's going to cut down a lot of anxiety, I think, for people providing residential aged care, Cynthia, and in terms of maintaining an accurate psychotropic register.
Yep, that's great. Thanks, Sam.
Looking at antidepressants, that's the next class that's commonly used. Antidepressants are used to relieve psychological and physical symptoms of depression. They're sometimes used to treat severe and persistent anxiety disorders. The role of antidepressants to treat depression in dementia is still uncertain. The most common class used and the first line for treating depression is the selective serotonin reuptake inhibitors. So that's the SSRIs. They're regarded as first line. Looking at the pie chart, you can see that mirtazapine is sitting at number one. That's 41% used in aged care, followed by Zoloft, which is sertraline, then by Lexapro, which is escitalopram, then Effexor, which is venlafaxine, and then aripiprazole, which is Abilify. So that's how they sit in terms of use. Again, they've got a lot of side effects, as all the psychotropics do. You've got nausea, weight gain, tiredness, trouble sleeping, dry mouth, blurred vision, constipation, dizziness. Now, selective serotonin reuptake inhibitors are also first line for general anxiety disorder. You shouldn't really be using benzos for anxiety as first line. So the SSRIs are the ones usually used as first line for this class. All right, and then another important class is benzos, benzodiazepine. They should be used only short term for treatment of insomnia. Now, obviously only after you've tried all other non-drug treatments. And then when they're used, they should be used for the lowest dose for the shortest possible time. They shouldn't be used long term. So the most commonly benzos used in aged care are Tamase, oxazepam, and diazepam. They're the most common ones that you see. Again, they've got a lot of side effects and mainly drowsiness, lightheadedness, confusion, unsteadiness, slurred speech, muscle weakness, and memory problems. Now, with the benzos, they do affect obviously the alertness of the residents. So you've got to using these medications is going to increase the risk of falls. So again, monitoring for side effects when you use these medications is crucial. Start at the lowest dose, increase if necessary, monitor, and try and cease.
Sam, great segue for falls risk. So Irene,
Absolutely.
as we know, yeah, greatest high impact risk affecting older people is falls risk.
And I think that's why the emphasis has been on deprescribing the benzodiazepines, because we do know that they do cause drowsiness, they do cause ataxia, and that ultimately results in a fall.
Anticonvulsants is the next class. Now, they're mainly used to treat epilepsy, and they're also known as mood stabilizers. They're used to treat seizures, and some are used to manage neuropathic pain. The most common anticonvulsants used in aged care are listed below. So we've got pregabalin, sodium valproate, which is Epilim, gabapentin, lamotrigine, which is Lamictal, and carbamazepine, which is Tegretol. You know, if they're used as a mood stabilizer, obviously that's going to be regarded as chemical restraint. They need to be used for seizures, epilepsy, and that sort of thing. Adverse effects include dizziness, drowsiness, fatigue again, and nausea and tremor and rash and weight gain. So all these psychotropics have very similar side effect profile.
Yes, Sam, just in relation to the anticonvulsants, it's important to call out the fact that particularly with the Epilim and the Tegretol, if they're taken in combination over a long period of time, and some older people that have a long history of epilepsy have been on these drugs sometimes for decades, it does change as people age their facial structure, particularly their jawline. The jaw recedes. And of course, we know that further impacts on nutrition and hydration status. And that in turn leads to a poor, I guess, a lesser quality of life and well-being for people. So it's an important call out that we sometimes, well, most times it's overlooked.
Yeah, thanks, Irene. The next one's opioids. Now, there's a big focus, you know, an increasing focus on opioids and their use in aged care. They should only be used really to treat acute pain or terminal pain. That's well accepted for those reasons, but they shouldn't be used for chronic non-cancer pain. The most commonly used opioids are oxycodone, buprenorphine, fentanyl, and morphine. Adverse effects, sedation, dizziness, nausea, vomiting, constipation, physical dependence, tolerance, and respiratory depression. So you're going to continuously have to increase the dose because the body will adjust and they won't be useful anymore. So you're going to continuously have to increase the dose. Death from an overdose is a well-accepted risk. Now, you really need to monitor fluctuations of weight with these sort of medications because any weight change can increase the concentration of any of these drugs, and that can sort of obviously increase the concentration in the system and lead to further
so Irene, that what good practice looks like is being aware of the consumer's weight, and particularly when the medical practitioner is actually visiting to complete a review, that there is a focus on the resident's current weight, particularly at medication review, to make sure, just picking up on Sam's point there, that that it is the right dosage for that person.
Yeah, and particularly if there's been a recent gastrointestinal upset of any sort and they've lost a few kilos quickly, or they're a little dehydrated. We all know the hypothalamus doesn't work quite as well as we age, and the hypothalamus is where most of the pain, I guess, initiation warning signs occur for older people. So you've got to look at the use of opioids truly into the aging pathophysiology of a person. But as Sam's rightly called out, increased weight or weight loss is definitely a lead clinical indicator for a review.
And no surprise, Irene, that it's part of the National Quality Indicator data set, which we'll come back to later, but you can see the connection here.
Oh yeah, and of course the aged care quality standards, which you're going to talk about shortly, I believe.
Yeah.
Okay, Cynthia, I think you're going to just enlighten us now that we've talked about psychotropic medications. What is restrictive practices and what are the types?
Yeah, thanks, Sadie. So if you're someone who's recently joined aged care, you might be wondering why there's such a focus on psychotropics. So that backdrop that Sam's just given us is really important, because that family of psychotropics may in fact have a connection here to restrictive practice. Now, this legislation change followed the Carnell-Patterson review. It came into effect from July, and we know from our work with aged care providers, there's still people wrapping their heads around the new definition. So let's just quickly touch on those. Restrictive practice, now we have 5 groupings. So chemical restraint, environmental restraint, mechanical restraint, physical restraint. So we saw mechanical being separated from our previous language of physical. And we now have a definition for seclusion. Now, in reality, we know that many aged care providers would automatically say that seclusion doesn't fall part of their restrictive practice, but it's important that everybody in your team is aware of it and its definitions so that we don't end up with any key misunderstandings. And I know that the connection here with chemical restraint is really what we're exploring between Sam and Irene and Sadie and I, making sure that that recognition of these principles from that family of psychotropics, then we're very clear about our obligations as practitioners and as approved providers when it comes to chemical restraint. Now, Irene, you and I know definitions have changed and there are a few things that people really need to get hardwired in.
Yeah, the lexicon certainly changed and some new terminology has been introduced into what was our daily use of descriptors around restrictive practice. So just for clarity, we're going to run through these quickly. The first thing is they've introduced a character called the approved healthcare practitioner, which is really 3 characters: the medical officer, the nurse practitioner, and the registered nurse. And these are the people that are key to making decisions about whether restrictive practice should be used or even considered for use. Informed consent has become more targeted in its definition. And what it means is that the consumer or their substitute decision maker has been provided with enough information, all information actually, and they've had the opportunity to review the information and to ask questions about anything related to the use of the restrictive practice. And then they've made a decision to have a restrictive practice used or applied as part of their care. Okay. There's now another character on the block called the restrictive practices substitute decision maker. Now, I want to be very clear here that the consumer may in fact have a substitute decision maker and then may have a different restrictive practices substitute decision maker. You can't assume that they are going to be one in the same person. So the restrictive practice substitute decision maker means a person or a body, and that's usually a statutory authority, who can give informed consent to the use of the restrictive practice in relation to the care recipient. And if, in the case of chemical restraint, the prescribing of medication for the purpose of using chemical restraint if the care recipient lacks the capacity to give that consent. Now, can I just also add here, because someone has a restrictive practices substitute decision maker, it does not exclude the consumer from being involved in the discussion. Wherever possible, even if the consumer is not able to have the capacity to give consent, they have to be included in the discussion, and that has to be clearly documented where appropriate. They've also talked for the first time about what an emergency situation actually is. And here we're talking pretty much about PRN medication. And they've said an emergency is a serious or dangerous situation. Now, the 2 key words here that we're coming to are unanticipated or unforeseen, and that requires immediate attention. So focusing on unanticipated or unforeseen. Situations where restrictive practices are required in residential aged care in the event of emergency should therefore be rare, very rare indeed.
So Irene, for me, that means that if part of the behaviour support plan, and we're going to come to these concepts as well, because this is other changes, then obviously for the resident, they will have a behaviour support plan if they have a medication that is classified as chemical restraint and it has a PRN element. That needs to be clearly part of the behaviour support plan.
Yeah, and I think, when we're talking about PRN medications to modify behaviour, particularly Cynthia, or to influence behaviour, you've got to be very careful what that PRN medication is, because it may have absolutely no use or no therapeutic effect in the situation if the person isn't titrated for it.
So those slides that Sam actually started with really bring into crystal focus, really understanding what the class is, what the purpose is, and then what could be the side effects, so that you're really understanding in that context what's going to be the right part of the
look, you know, in our work, Cynthia, we've seen things like a PRN medication for risperidone, which is absolutely useless because it's not being supported by a therapeutic dose. And then people are going, hey, this didn't work. Of course it didn't work.
Yeah, because you would need some regular element to it.
Yes, it's got to get up to a therapeutic level within the blood. It's got to have a good serum titer in order for the PRN to actually do anything.
Yeah, that's really helpful, Irene. So let's keep understanding these changes to restrictive practice. So again, very high level. We're not taking you into a complete deep dive of a restrictive practice. If you would, there are 2 webinars that we have available complimentary on the Anchor Excellence website. But let's just, for the purposes here, just be really high level. Critical importance: the provider has documented change behaviours or behaviours of concern, reactive or responsive behaviours for the consumer, where these change behaviours have been assessed by an approved health practitioner. So Irene, that's the medical officer, nurse practitioner, and the registered nurse. So
correct,
we've got
yes.
clear understanding of that backdrop.
Absolutely.
Who has day-to-day knowledge of the consumer, or a behaviour support specialist. So that's a good call out to Dementia Services Australia, the resources that come from Dementia Training Australia, but there is also the 1-800 number, which we'll come back to later, which is an extra resource.
It's important here to consider what a behaviour support specialist actually is, or who that person is. And depending on the context, for example, if it's an NDIS context, if you have an NDIS consumer, that person has to be accredited and recognised by NDIS.
Now, the next point for me, Irene, is particularly important when it comes to chemical restraint. Now, we talked a little bit before about the use of PRN. Alternative strategies have been used prior to the use of any restrictive practice and informed consent. And I think probably for me, Irene, the big implication here is behaviour support plan, and particularly picking up responsive behaviours overnight, and so that the night staff team are really clear about what the alternative strategies are and making sure that they have documented those and track them through.
Look, and there's many strategies that can be used before restrictive practice is even considered, Cynthia. And I think people have been practitioners and registered nurses at that level have been limited by their own imaginations about what's possible for people.
And the final point here, everybody, is that these changes actually build on previous changes. So in 2019, during the Royal Commission, there was an amendment to the legislation, the Quality of Care Principles. Those changes to the restrictive practices have now since been built on in these last amount of changes. So it's important to understand this is a changing environment, but really this last change is the most substantive and will likely stay in play for a while. Now, those handouts that Sadie mentioned that will be coming to you, the one of particular note is Regulatory Bulletin 2021-13. Everybody needs to be familiar with that, and of course having good policy and process to guide your practice. Now, Irene, you and I know it's more than just simply saying restrictive practice belongs in Standard 8. So if I go to Standard 8 first, we know that minimising the use of restraint is particularly called out there, but it actually has an intersect to many of the other standards. Now, if I just touch on Standard 1, for example, this is all about consent, consumer dignity and choice. So how is the resident being supported with their decision making? So hence the connection to decision makers, substitute decision makers, and of course now with restrictive practice, we've got the restrictive practice substitute decision maker. Standard 2 is all about comprehensive assessment and planning with consumers. So that co-designing, Irene, of those behaviour support plans and those care and service plans with the people who the plan applies to is absolutely fundamental, but again, not new, been around in the standards now for well over 2 years.
I think it's really important here, Cynthia, to stress over and over again, you cannot have restrictive practice in use without a behaviour support plan. It's that simple, it's the law.
Yeah, That's correct. But again, the intersect to the standards here. Now, standard 5, for example, as a call out, brings focus to the ability for consumers to move obviously inside and outdoor areas. So we can see a subtle connection here to environmental restraint. Feedback and complaints, of course, standard 6, how you are listening and responding and co-designing and engaging consumers. And then, of course, the workforce capability. So standard 7 really kicking in here. Do they understand your policy, your process, whatever the mechanisms you've put in place? How are you confident that they're competent and they're confident in their use? And of course, then in standard 8, pulling it all together as I guess a bookend, making sure that the governing body in particular has the connection to clinical governance oversight of your restrictive practice particularly, but also how are you measuring that? How are you quality auditing to be confident that your systems and processes are actually being adhered to?
Standard 7 is really important here, Cynthia, because the training plan should go to the core of that.
Yes.
There's been exponential change and more is on the way with the second tranche of legislation coming through shortly. And all of that taken together must be reflected in their training plan.
Now, the other element, Irene, of I guess the regulatory landscape is the national quality performance indicators. And we have seen some changes here, but these ones are in the medication management ones are in particular call outs.
Yes, and this actually goes to the nub of having a sound, I believe, an electronic medication system, because all the data that you need to report to the National Quality Performance Indicator slate can be collected through an electronic medication system. And then further, if you've got an electronic care system such as QPS, or moving on audits, they gather the data up, they collate the data and lodge it for you. So the two go hand in glove, and they're just a really neat way to collect the data rather than to try to do it as a paper-based and lodge it yourself through your own service. But what's changed is important. You now have to report on the percentage of care recipients who were prescribed 9 or more medications, and that is polypharmacy. And also the percentage of care recipients who received antipsychotic medications. And if you think back to one of earlier Sam's slides, he went into what the antipsychotics do, their side effects, their adverse effects, and their potential for harm to the consumer. So there's definitely a very strong tie back to the National Quality Performance Indicator program.
And Irene, the same thing there is the connection to both, well, particularly for residential aged care providers, the risk-based questions and the initial documents at the beginning of any assessment visit. So assessment visit for site audit, assessment visit as a regular monitoring. Part of those questions include the psychotropic register, the percentages of each of the grouping. Then there will be likely sampling from that grouping to cross-check and be very clear about the restrictive practices register, whether or not the restrictive practices are actually compliant. And then, of course, the final piece is if there has been any identification of inappropriate restrictive practice, that will segue to the serious incident response scheme.
Absolutely. You know, SIRS is here to stay. And I think that it's probably a good thing that it is in place.
Just on the previous slide, Irene, sorry, just
sure.
to add on the previous slide that specifically with those two reporting indicators, the polypharmacy one is something that's not as easy to report on anymore because you've got to be excluding PRNs and creams and lotions and that sort of thing from your report to actually report on true polypharmacy, people using more than 9 meds. So, and with the antipsychotics, again, having a 7-day administration period you've got to report on rather than just getting a quick report on everything. So having a system like BestMed, which does that for you, will make it easier for the facility, for the clinical pharmacists, for the prescribers to sit there and highlight the residents that are being affected and review them appropriately. I think it's essential to be able to do that at the click of a button. rather than having to sort of, take a lot of time to produce this data.
Sam, just before you move off this, there's a question from the audience requesting the definition of polypharmacy. So could you just go into a little bit more detail, please?
Polypharmacy is any consumer using more than 9 medications. Those 9 medications basically are any medication with any. It could be even over the counter with an active ingredient that's regarded as a medication. But then you've got to exclude out of that list of medications on the chart things that basically are lotions, creams, and short course and PRNs. So that's what you exclude. Then you've got true polypharmacy, and you can highlight those consumers to get a medication review by a clinical pharmacist service, make recommendations, sit down with the prescriber and look at Deprescribing, which we'll look at in a bit more detail a bit later.
So we've got a really clear messaging here: understand polypharmacy, understanding the family of psychotropic medications, particularly understanding antipsychotic medications, measuring that, looking for improvement over time, connecting it to the standards, connecting it to the serious incident response scheme, which comes with an incident management system. So again, this regulatory change brought into focus those incidents that do classify as priority 1 or priority 2 incidents that must be disclosed within specified timeframes through to the Commission via the portal. And it's important that that the team on the ground are able to recognise these definitions and also know where a reportable incident is also warranted. Irene, did you want to add anything else on that slide?
No, only that it goes again to the heart of inappropriate use of psychotropics and the absolute dangers inherent in that, in doing so.
So if we quickly just recap, we've got a lot hitting aged care providers and staff, managers, team members working in aged care. So it's really important that there's a good understanding of those new definitions and the new requirements. So we can't stress enough the importance of good policy and process. They are strengthening and better clarifying existing obligations. So we have called out, as we said, mechanical and physical. We have this new one, seclusion. Chemical actually hasn't necessarily changed, but we've got an improved focus when we connect to restrictive practice. Definitely tighter expectations around minimising the use, and particularly as we're now in September, the use of behaviour support plans. And making sure that cornerstone around informed consent, particularly with the restrictive practices substitute decision maker. Good clarity around what is an emergency, and that definition, Irene, that you covered. We can't stress enough the importance of understanding the words emergency are not, we had an escalation in behaviour. That should actually be anticipated. If it was foreseen, we should be able to see that strategy well articulated in the behaviour support plan.
Absolutely. And it should be very, very rare.
Yeah.
So Irene or Cynthia,
yeah,
whose responsibility is it to ensure that consent has been obtained?
That's a very good question. And if you look at an accountability matrix in a home, it usually rests with the care manager under the delegation from the facility manager. So the care manager is ultimately the person that should be checking that consent forms have been signed and that the consent is of an informed nature.
In the practical day-to-day, Irene, the medical
the registered nurse is the conduit to the medical officer. And it's usually that's where the interface generally occurs. However, if the registered nurse is having some difficulty with the medical officer, then it's escalated to the care manager and then through to the facility manager if it's ongoing.
I think the call here, Irene, is the connection to informed consent and the role of the medical practitioner has definitely been.
Oh, absolutely. You know, a medical practitioner is now obliged to sign a statement to say that they've spoken to the consumer or to the restrictive practice substitute decision maker, that they've explained it. And then that person that is giving consent has to say, yes, it has been explained to me by Dr. blah, 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 and I understand the implications. It's tightened to that extent. Now, I don't for a moment think the medical officer is going to enjoy this at all. And from I guess my experience only in the last few weeks, I've had a lot of questions about what do I do with a recalcitrant medical officer? And all you can do is escalate it through to the facility manager and the clinical governance committee. You can try education. You can, prompt as much as you can. But at the end of the day, if they still are not being compliant with the law, I got one email from a medical officer saying that she simply didn't have time to do this. And all I could reply was, well, I'm sorry, it's the law. And if you can't comply with the law, then you won't be able to see residents in that nursing home. It's as simple as that.
Thanks, Irene.
Thank you.
So let's kind of shift now into that specific stuff, Sadie, of chemical restraint.
Yes. So what is a chemical restraint? So this would not be new to you all. You would have seen this already. This is embedded in legislation. So a chemical restraint is a practice or intervention that is or that involves the use of a medication or a chemical substance for the primary purpose, and this is important, primary purpose of influencing a consumer's behaviour. But it doesn't include the use of medication prescribed for a diagnosis of mental disorder, physical illness, physical condition, or end-of-life care. And examples of chemical restraint also include any PRN medications or as required, and over-the-counter medication to a consumer, which also influences, moderates, or controls their behaviour. So you would all be familiar with that. So Irene, can you talk to us a little bit?
Yes, yeah, I'd love to, thank you. So if chemical restraint is prescribed for one of your consumers or your residents, the first thing that you need to do is to consult with the consumer or the restrictive practice substitute decision maker if the consumer does not have the capacity to provide consent. Now, the consumer may well want that restrictive practice substitute decision maker involved as well, and that's perfectly appropriate. The approved health practitioner, and just to run through who they are again, you've got your medical officer, you've got your nurse practitioner or your registered nurse, must obtain consent from the restrictive practice decision maker if there's no capacity. And the approved health practitioner needs to explain the following: the reasons why the chemical restrictive practice is necessary, the potential side effects or adverse reactions, timeframes for review, and monitoring intervals post-administration of the medication, and deprescribing strategies once behaviour has been managed. Now, we didn't pluck this list out of the air. This is taken directly from the legislation. And I think it's 15H or something like that, is it, Cynthia?
Yeah.
Yeah. And that's why education for the medical officers is critical. They've had a pretty free hand up till now, but part of the tightening is to educate them about the actual damage that these categories of medication can cause. And also, as the approved provider, you need to be confident that the consent is informed, it's been obtained without duress, and the restrictive practice substitute decision maker is aware of the above. Now, having said that, can I also stress that this consent can be withdrawn by the consumer or the restrictive practice substitute decision maker at any time, and that withdrawal of consent must be respected.
Now, Irene, you and I know one of the things that we've had anticipated in other webinars is, or how frequently should be the review? And the legislation is purposely silent on that point.
Yes.
Because it should be really something that is part of the plan for that individual consumer.
Yeah.
What comments would you add there?
Well, I'd just say that, as a team, Anchor Excellence regards 6 weeks review as best practice. Most policies that we've reviewed for organisations have had a 12-week review period, but whatever review period you determine, what you have to also have in place are caveats, such as if the patient deteriorates, if the consumer deteriorates, if the consumer's behaviours change, if their cognition changes, anything that is different about the person would trigger a review.
And
that's the important part of whatever time frame you put on it. It comes to the date, back to the definition, the day-to-day knowledge of that person. You live with these people, you work with these people. You're probably closer to these people than anybody else in the universe. You need, on a day-to-day basis, to be able to monitor the impact of those medications.
And Irene, for me, I can't help but segue. We're regularly monitoring weight loss for lots of reasons, but we also
totally
want to connect the relevance here to these dosages as well. So if you've had someone who's had a very sudden weight loss, we also want to be thinking about medication as well, not just nutrition and hydration.
Well, exactly. And, you know, the interaction of medications, you know, it's like a cocktail for some residents. They have polypharmacy. And if you've got a subtle weight loss or weight gain, that's going to upset the pharmacokinetics and pharmacodynamics of that particular medication, either singly or in combination. And that's something that we must never lose sight of.
So again, just to circle back on those obligations. So what does good look like, and what are the things you need to have in place? Clearly, behaviour support planning to make sure that it is reflective of those behavioural needs for that consumer, and what the plan of management is. Have a regard for any SEERS reporting. Obviously, if that there's been examples of that in appropriate restrictive practice. Make sure that you check the monitoring is occurring as per the prescriber's instructions. So that element, we can't stress enough that that's picked up. Make sure that there is that review period, Irene, that you called out, and it's set at the discussion point with the consent, the informed consent phase.
Sorry, Cynthia, can I just interrupt there and say this is a matter for your medication advisory committee in concert with your clinical governance committee. There may be some medications that you think are require closer monitoring than others. And so you may have an exemption list where that's done on an ad hoc basis.
The resident medication management review. Now, Sam, that's a really key one, isn't it? Making sure that they get scheduled and they're followed up. And we've got, again, the benefit of an electronic medication management system definitely helps those RMMRs.
Yeah, 100%. So medication reviews, I mean, the residents are entitled for them. So you should always be recommending a resident or a consumer for an RMMR whenever there's, you know, the changes in the resident, whenever there's medication changes, whenever there's a new psychotropic that's been added, whenever there's a dose increase or a decrease in psychotropic, they really need to have an input because they're a very important part of the team.
And the best way to bring that all together is good comprehensive care and service conferences, which would include the restrictive practices substitute decision maker. That will definitely help Irene informed consent, and being really confident about what are the alternatives available to make sure that they are in fact being used, and the behaviour support plan will be a great resource for that.
Totally.
So circling back to restrictive practice in the case of an emergency.
So look, this is a really important piece of information. And again, can I go to the rarity of its use? And again, it's unanticipated or unforeseen, and you've got to deal with it immediately. If the restraint is used in an emergency, the information must be documented as soon as practicable after the restraint starts to be used. So don't leave it till the end of the shift. Your memory's not that good, seriously. If restraint is used without consent in an emergency situation, the consumer's restrictive practice substitute decision maker must be informed as soon as practicable after the restraint starts to be used. That means also that the flow-on effect of getting consent must happen quickly.
And then, of course, we circle back to the behaviour support plans. Obviously, we've clocked over this time frame, Irene, of the 1st of September. Now, Janet Anderson, in her information session, did flag that there is time for providers in the next 2 months in particular to really make a move as they're moving towards those. They will have already had, though, understanded 2 care and service plans for behaviour support. This is now a review and a strengthening of those plans, and we're now using language calling them a behaviour support plan. In the legislation, there are some particular requirements that we don't want to be confused about, including the collation of assessments regarding those responsive behaviours, being really clear about triggers that may precede those behaviours. What are the alternative strategies that you can learn from the consumer, from family members, others that know the resident really well, that are successful, and also those that may not be successful, so that the care team are really aware of that. And obviously the circumstances where a restrictive practice. So we really want to be quite clear around this escalation process.
When you're talking about successful and unsuccessful behaviour, Cynthia, what you've got to realise also is that from time to time, something that was successful yesterday may not be successful today. That doesn't mean you discard it on a long-term basis. You've got it in an inventory of interventions that you can come back to from time to time.
Agreed. And so, Sam, let's circle back to deprescribing again. Part of the whole reason for this focus from a regulatory perspective is to see an active monitoring of the family group called antipsychotics and psychotropic medications. Then we've obviously got the connection to restrictive practice, chemical restraint. Sam, what does deprescribing look like and what's its benefits?
Deprescribing benefits are, I mean, there's a whole list of them there to the resident. Deprescribing should be a collaborative effort between the facility, your clinical pharmacist, as well as the prescriber and even your supply pharmacist. And this stuff should be these reports should be generated on a regular basis every month. They should be brought into the medication advisory committees and discussed. Residents that are using more than 9 different medications should be highlighted as using too many medications, and the whole thing should be reviewed in view of decreasing or ceasing some of the meds. Now, obviously some of the benefits are improved health and well-being for the resident, improved engagement and meaningful activities, improved function and quality of life, reduced polypharmacy, reducing drug interactions, adverse effects, which is a big one, because every medication has side effects. The more medications you have, the more interactions, the more side effects. Reduced rate of falls, reduced potential for medication errors, reduced potential for death, and obviously compliance with the standards. They're big benefits for the residents for using less medications. Now, deprescribing strategies, like I said, should be a team effort, and having obviously a good system in place to report on these things easily will definitely help. So looking at, for instance, PRN medications, just generating a report, which one aren't being used, which ones aren't being effective, trying to cease those, looking at, over-the-counter medications, looking at any medications that aren't effective, aren't needed anymore, and decreasing the use of those. So monitoring and reviewing the consumer. Non-pharmacological approaches should be maintained whilst on the medication and during withdrawal and cessation of the medication. So it's a big topic, and it's a very important topic.
Okay, so we'll move on to our case study. I note that we're running out of time, so I'm not sure if we'll have time to get through the second one. So we'll start with the first one. So Paul is an 88-year-old man who has been living in residential aged care for the last 8 months. He suffers from depression, anxiety, insomnia, osteoarthritis, hypertension, and dementia. When he first came to the home, he was exhibiting behaviours that were resolved with activities that he liked to undertake. Over the last 2 months, there has been a steady decline in his cognition and general condition, and an escalation in his behaviours, to the point that he is frequently calling out and is awake most of the night. Paul has begun wandering and getting into other residents' beds. The GP was contacted and prescribed both regular diazepam and risperidone PRN to manage the escalating behaviours. So, Irene, can you talk to us a little bit about what considerations should occur in a situation?
Yeah, sure.
Like this? Thank you.
No problem. Look, Paul is a fairly complex character. In the short term he's been there, you can see that there's been a deterioration in his cognition, and therefore some other interventions may have to be considered. So before we actually move into the realm of chemical restraint, firstly, you need to have a good understanding of your resident. And it goes back to that initial definition that was shared, day-to-day knowledge, understand, know the person, know your person, basically. Support Paul, so that this includes increased monitoring and supervision, review behaviour charting and understand trigger events. Now, just in terms of trigger events, what might be a trigger event today may not be a trigger event tomorrow, but you need to have, again, a good inventory of what the trigger events are for Paul, and try to avoid putting him in that situation as much as physically possible. Try and identify what's changed for Paul. Has he had a fall? Has he had an infection? Do his medications seem to be having the same impact that they did even a few weeks ago? Have significant relationships changed for Paul externally? Does Paul have any unmet needs? And here we think about thirst, hunger, continence, pain. Does he have wounds that are causing him distress? What are Paul's unmet needs, particularly if his confusion and cognition are declining? Have a look at his surroundings. What things in the surroundings are annoying him? Can you modify his environment so some of the known triggers simply aren't there? And we know that noise can often be a trigger. And if Paul is in a room where you've got 3 people's televisions, all on different channels, all competing because the person's got a bit of hearing impairment and they're just getting louder and louder and louder, and then Paul's behaviour changes, it might be a good idea to think about where Paul's actually living. Identified strategies that have had a settling effect on Paul, and refer to the care and services plan and behaviour support plans to get support if you're unsure, if you're new to Paul or Paul's new to you. Identify what is and isn't working just on a day-to-day basis. Importantly, understand the risks to Paul and to others. Now, the whole purpose of any form of restrictive practice is safety for Paul and for everybody else in his environment. Okay, and that includes staff, visitors, contractors, and particularly other residents. Can you mitigate the risk, and can you remove or reduce the risk from Paul and others in the environment? There's a few other considerations, I think, too, Sadie, if we move to, we looked at infection, constipation, pain, delirium. Delirium, a very simple definition of delirium is acute confusion. And we know that delirium is often caused by an underlying infection or an underlying change in just something as simple as weight. A medication review that Sam has touched on. Review care and services plans, behaviour support plans, and make sure they do identify behaviour, triggers, strategies, and particularly calling out strategies that you know just will not work in the future. A care and services conference with the consumer and the approved health practitioner, the restrictive practices substitute decision maker, is important to identify perhaps things from his past that might be useful. Now, the GP's ordered regular diazepam and risperidone PRN. If this is this a chemical restraint? Well, yes, in this instance, it most certainly is. Risperidone might be used primarily to managing his wandering behaviours, but still that is exerting an influence on his behaviours and perhaps preventing him from being where he wants to be and doing what he wants to do. And again, it should be a last resort for the minimum time. There's a motto, go slow, go low, go slow. And I try and reinforce that wherever I can.
Yeah, that's really, really good, Irene.
I don't know that we've got time for scenario 2. We're running out of time. So maybe this is something that you can have a look at yourselves and go through. And if there's any questions, come back to us. So Cynthia, we might slip down to the next few slides.
Yeah, so we'll just make a wrap here, Sadie, to really reinforce what do you need to be sure of. Good, clear policy and process linked to your governance. So remember, in the aged care standards, governance is the oversight. It connects through to the governing body, but it'll include your quality systems and your processes by your reporting. Make sure you've got really good, clear roles and responsibilities between those who consent, those who prescribe, and those who administer. Make sure that your crew on the ground definitely understand behaviour support planning, build capability, including their understanding of chemical restraint and what your obligations are. As Sam says, make sure you use effectively the RMMR. We see this often as an issue as we're working with providers. Make sure you are fully utilising your clinical management systems, because as Irene touched on, record keeping is particularly important with this regulatory change, and you do want to see a good functioning medical advisory committee. And through your medication management systems, really connecting the information flow between the prescriber, the pharmacist, the provider, and of course those who are administering, to make sure that they are compliant. And of course we know that this is well managed when you have an electronic medication management system. And Irene, it goes without saying that in this evolution of aged care, systems are very important. So
absolutely.
Clinical management systems and medication management systems, you want to make sure that they are aligning your service with the pharmacist and the prescriber on one platform.
Can I just interrupt, Cynthia, and say that point is particularly important. And when the commission auditors come on site, they want to see the robustness of the systems and how they interrelate. And if you've got a single platform that pulls it all together, they really do like it, because it just ticks all their boxes.
Well, it minimises so much risk, because you don't have to go and navigate through a whole lot of information. And the more automated it is, certainly the more reliable the information it is. Obviously, as Sam said, managing, monitoring and reporting on the use of psychotropic medication. Now, we flagged here antimicrobials, because also under Standard 8 connected to medication management is antimicrobials, not the focus of this webinar, but an important one to remember. Making sure that you've got the medication charts that are due for review. Again, if they're all integrated into one system, that certainly makes life a lot easier. Of course, connecting it to your Standard 8 obligations, you want to be able to make sure you've got the information at assessment visits really readily. So your risk-based questions and your initial documents.
Absolutely.
Being able to turn that around quite quickly. So we've flagged psychotropic assessment, drug usage, antimicrobials, polypharmacy, and of course, a particular focus around PRN. And of course, the connection to national quality indicators, being able to retrieve that information for your reporting, being able to monitor for also your obligations under the Serious Incident Response Scheme. And we know that medication management systems really do help you get a much tighter and cleaner focus around consumer risk, which is a really important element. The Royal Commission into Aged Care and even the Carnell Patterson review back in 2017 was without doubt a strong focus on restrictive practice as well as medication management. So we're really seeing that come to the fore as we really start to focus on polypharmacy, psychotropic medications, and of course, restrictive practice. So I think, Sadie, that brings us to the end of our webinar, and I'm sure that there are other questions that people have. We're going to make this webinar available, but also we have the opportunity to follow up directly with us. So you've got our details there for Anchor Excellence, and of course, Sadie, for BestMed.
Yes, and thank you everybody for joining us today. We hope you got some benefits out of that. We've certainly tried to cover our objectives of linking the pharmacology, the clinical and the legislation together. So as I said at the beginning, we'll take your questions on notice and we'll respond to you with a frequently asked questions sheet. But we will stay online, I think, Cynthia, for a little bit longer if people have got some questions. So once again, thank you, and we look forward to seeing you again.
Yeah, bye everyone.
Okay, so Sadie, I think we've got a couple of questions. For those of you who would like to stay on, we're going to just canvass a couple of the questions now. Yep. So the one of them in there, Sadie, is probably a good one for Sam. Sam talked about doing an ECG prior to commencing some psychotropics. Sam, do you want to comment a bit more on that?
Yeah, so a lot of the antipsychotics increase the QT interval. So if someone's got problems, heart problems, existing, cardiovascular issues, it makes it even worse. But doing an ECG will determine if there's any underlying issues before starting these medications, because they're going to increase risk.
Mm-hmm. Thanks, Sam. There's also a question here, probably for you, Cynthia.
Yeah.
Or Irene, if a resident is on chemical restraint since admission, does this require reporting it as SIRS?
Well, no, I wouldn't say it requires a reporting. It's part of standard 2 to start your processes for assessment and planning. So really understanding the history. So in our assessment processes, we'll be engaging with residents and their family members or whoever is helping them at that point. We really want to be quite clear, though, about that substitute decision making, because remember, we've got that flag of the restrictive practices substitute decision maker. So there is a bit of education that needs to happen, as we would call, in that transitioning into care phase. And of course, working with the appropriate decision maker to identify with the medical practitioner, is there opportunity to actually remove those medications? They may have come with the consumer, but they may not be taken. And if they are to be taken, then of course we want to see the use of the restrictive practices strategy. So remember the behaviour support planning, as well as the appropriate informed consent. So we're complying with the legislation. Irene, would you add anything else?
Yeah, look, an interesting question that just popped up while you were talking about that, Cynthia, and it was about people that have been on admission, have been on a chemical, what we could consider, or a psychotropic at least, for 4 or 5 years. Now, there's probably a high level of habituation already occurring for that person. So anything that you do has to be really carefully thought out, carefully assessed, and you may never be able to remove those medications from that person's profile. However, what you can do is try to minimise the use and to reduce the dose over time. But whatever you do, it has to be a very graduated approach because of the fact that they've been on it for so long.
Irene, there's another question about the use of temazepam. Now, Sam, you flagged that really temazepam falls into a particular class. It's not something that you'd want to be using all the time, but it will be used particularly for insomnia. So there's a question around that, Irene. If the person has a diagnosis for that psychotropic medication, will that classify as chemical restraint?
No, not at all.
Sam, anything else that you would want to add on that?
No, it's with a diagnosis, obviously, like insomnia for Tamaz, that's an accepted diagnosis for it. So it's not a restraint, but again, we should be reviewing that medication regularly and trying to sort of reduce and decrease and cease because of the common side effects.
Now, Natasha's, sorry, Sadie.
No, sorry, you go.
Natasha's asked a question that says, if the person has cognitive impairment and we decide to administer this medication, would this be considered chemical restraint as we are making the decision for this client? Now, that's a great question, Natasha. And I would say to you, what it throws up for me is a couple of things. Have you actually got an appropriate decision maker? And that instrument, it really depends on which state or territory you're from. So it's important to understand that the legislative construct of a substitute decision maker is a state or territory oriented component. The doctor is not just simply ordering medications and we give it to people. So health practitioners don't make decisions for people. Obviously, consumers make decisions. This is why we're seeing this emphasis around a restrictive practices substitute decision maker, really calling that out because the chances of a lack of capacity is much higher, particularly if you've got cognitive impairment. It will be chemical restraint if it has the influence. What's the words, Irene, regarding the behaviour?
Whether you're trying to modify or change the behaviours, it has an effect on the behaviour of the person.
Yeah, so we've got to really make sure we've got those foundations laid down correctly and it's compliant to the legislation.
Yeah, totally.
So Cynthia and Irene, here's another question, and it relates back to consent. So it says, no, it's just moved, sorry. Let me just find it. What is the stand on getting consent if the resident has no family or friends willing to make decisions on behalf of the resident, public guardian no longer stays as medical power of attorney, nor will they make decisions or give consent for restraints. What can we do if unable to get consent from anyone?
I would think it would be a very unusual situation where the public guardian could refuse to be involved. I know different states call it different things, but there's something in every state or territory in Australia where someone who can't make decisions for themselves due to lack of capacity, there is a statutory authority that has the capacity to do that for them. It's up to the facility manager to be able to identify what that authority is and to make an emergency application for a hearing. I would find it highly unusual if, for example, the Guardianship Board in New South Wales refused to deal with somebody.
And Irene, I would also interject there by saying it's decision specific. So when you're putting through an application, you want to be really clear what the healthcare decision is. So in this case, it's consenting for a restrictive practice.
Yeah.
Obviously, the connection to the behaviour support plan. You don't just put in an application that says, oh, this person hasn't got anybody, so therefore we need someone. You actually need to connect the actual healthcare decision.
You have to be very specific. That's correct. Yes. You know, you've got to describe the behaviours. You've got to go into a lot of detail about the medication, what it should do, what it may not do, and the risk involved.
So Cynthia and Irene, that could the legislation be different in each state pertaining to guardians and consent, etc.?
Look, it is, and it's incumbent on people in each state to be familiar with that. It's essentially, there are a lot of commonalities that run across all the different state and territorial jurisdictions in the legislation in relation to guardianship. However, you've got to learn to massage what is best, what's happening in your own state and territory. I mean, and most organisations, if they are running into functional problems, that they should have some redress to some sort of legal advice to move the process along.
Would it be possible that they could go to the commission in their state and get advice from them?
The Aged Care Quality and Safety Commission. Yes. They may be happy to provide advice, but they may also be agnostic about it and say, well, it's up to the approved provider to actually navigate that as part of their approved provider responsibilities.
I have one question here for you, Stan. How often is an RMR allowed to be conducted on a resident?
RMR reviews can be done once every 2 years, but now the departments allows also 2 follow-up reviews. So really, you get the review done, and then you can have another review in a month and 6 months. If you that way, it's sort of you're following up to see if the actual if the prescriber has actually taken up some of these recommendations or not. So they're really useful. So 1 + 2 reviews.
And so it would be very useful on return from hospital for an RMR to be done on a resident. Is that?
Yeah, so 100%. So anyone returning from hospital, anyone who's been admitted new to the facility, or anyone that's had medication changes or change of condition.
Okay.
Sorry, Sadie. So just to add on that, so if you've had you've had your RMR for the 2 years and you go to hospital and come back, you can be entitled to another one. So you can have multiple RMRs with these changes.
And look, here's a question on, is BPSD still regarded as a diagnosis to support the use of olanzapine for someone exhibiting paranoid behaviours and aggression associated with dementia? Cynthia, Irene, could you answer that one?
Oh, I might handball that one to Sam, I think.
Can you repeat that, please, Sadie? Repeat the question.
Is BPSD still regarded as a diagnosis to support the use of olanzapine for someone exhibiting paranoid behaviours and aggression associated with dementia? So basically,
so I think that if you've prescribed the medication for a condition, diagnosed mental condition, diagnosed condition, that's fine. But if you're actually treating it for a symptom of that condition, like behavioural psychological symptoms of dementia, for instance, where that's could be agitation, aggression, all that sort of thing, that is a chemical restraint because you're targeting a change in behaviour.
Okay, thank you.
There's a question, Sadie, just saying how often do you have to get consent? And I think it's important, whoever's asked that question must be prior to the use of restrictive practice. So again, you need to refer to your organisational policy and process and how the consent forms. Now, every organisation will have their own approach. Important to know that if you aren't actually ready with your policies, your processes, your education materials, Anchor Excellence, we do have a complete package that deals with all of your obligations for restrictive practice, as well as behaviour support planning and training. So you are welcome to reach out and have a look on our website, and they are tailorable and editable. But that person who asked that question, please refer to your organisational policy and process. Condomed's asked a question, Sadie, about consent.
I was just going to raise that one, Cynthia.
Yeah. Well, consent is both verbal and written. The critical thing is the evidence, and the documentation obligations of these changes, Irene, are critical. So of course you can record certain consents in the progress notes, but you definitely want to connect care and service reviews and a discussion where there is also an element of written consent. So you've definitely got an evidence pathway. Because remember, the changes with restrictive practice, it's not just a form set and forget. You've got to remember that there's more obligations here, which we've covered some of those in this slide deck. What else would you add?
I would just say that the definition that we flagged about informed consent is very clear about the requirements for consent. And it's based on knowledge and understanding of the type of chemical, the classification of the drug, the anticipated effects, the side effects, the adverse effects. It's full disclosure, I guess, to the person making the decision about whether to use it or not. It's crystal clear in the legislation.
Look, I think that brings us to an end of our extension of time. As we indicated before, we'll be sending out responses in due course to the other questions and on our panel list there. Again, thank you very much for joining us. We really look forward to seeing you again next time.
Thanks, everybody. Have a great day.
Take care. Stay safe. Bye.
Thank you.
Bye. Bye.